smoke that get lung cancer, believe it or not. So sometimes it's purely just bad luck. So here's the statistics, if any of you like the stats. About 228,000 new cases. This is from 2019. I looked at the data last night actually, and then there's 238,000 is what it was for 2021. So really not a huge difference in cases, right? So this for quite some time has been around these same numbers. Even though they have more cases, there is also still a lot of people that die every year. Why do you think that is? Think about screening and prevention. There's no really good screening for lung cancer, right? Like we do colonoscopies, we do mammograms, we do lab draws for a lot of other things, cancers, but there really isn't any good screening for somebody who has lung cancer, right? Even if they've smoked for years and years, about probably 12 years ago maybe, probably longer than that, Medicare and Medicaid, so the CMS, decided, hey, we have to do something to try to prevent all these people dying of lung cancer. We have to do something to catch it earlier. It's very expensive, right? People who have lung cancer, it's very expensive. It's very taxing on their body. They usually spend some time in the hospital setting. So they rolled out that anyone who smoked, was a heavy smoker, could do like a low dose CAT scan once a year. But they found that they really weren't catching a lot, and the risk of the radiation from the CAT scans was actually more to that patient. They were giving them more radiation than they needed in a lifetime than the benefit of catching maybe one or two early cases. So they didn't really think it was in their best interest to continue to do that process. They really don't have any good screening for lung cancer. Just prevention. But there's a lot of people out there that get it that have never smoked. So it's often diagnosed very, very late because of that reason. So it's classified as basically two types, small cell or not small cell, okay? Both are very aggressive. Small cell is definitely much more aggressive form of cancer. The non-small cell is a little more slower growing than small cell, but both very aggressive. Small cell tends to respond to chemo very quickly. So a lot of times once they start treatment, they'll feel better right away, but it also tends to come back a lot faster. For non-small cell, they can sometimes do different chemos and kind of keep it at bay for a longer period of time. So it's also categorized as adeno or squamous. So squam obviously comes from you have like squamous cells on your skin or like the lining of things, where adeno is more inside the actual organ. So it's just the cell where it's based from. And then there's also large cell. You guys don't necessarily need to know all those, like adeno, squam, large. Just know the difference between non-small cell and small cell are really the two types. So when we look at a comparison, this is a slide out of an old book, but it's still pretty good. The top picture is small cell. So you can see how much larger that is, very aggressive, and it grows very, very rapidly. So small cell lung cancer isn't even stage 1, 2, 3, 4. It's stage limited or extensive stage, because it's very rare that they catch it early, and the only way they can cure it is if they catch it early and can get rid of it, so surgically remove it. But most cases, they have to most cases it's already extended. It's already spread somewhere else, and that's the symptom that they present with, and when they find it. Where non-small cell, they're smaller tumors typically, they don't grow as rapidly, so it happens more over time. For small cell, it's a lot more progressive. So this says more than 40% of clients have metastasis at the time of diagnosis for small cell. I would say it's more probably 60 to 70%. It's a lot higher. So small cell is much more extensive, much more aggressive, grows more rapidly. where non-small cell, still an aggressive cancer, grows slower. So it's when these cells mutate, they act abnormal, just like any other type of cancer. They misbehave. We know that people who do smoke, they're inhaling carcinogens that damage the lung tissue, damage the DNA of those cells. So those sometimes that is that direct correlation. But like I said, there's a lot of people who've never smoked and they get it. So there's other risk factors, like radiation exposure, so environmental. Radon is a huge one, we already talked about that. So the gas that's in the soil in a lot of areas and people inhale that in, puts them at risk. There is some genetic components. They don't know a lot about specific genes for lung cancer yet. I do feel like it's coming down the road. It's also a cancer because it has such a high mortality. There's not as much research on it, which is really sad. Like there's a ton of research and money that goes to breast cancer every year, right? A ton of research that goes to leukemias and lymphomas, a lot of times because those affect children. But there isn't as much money put forth to really go after trying to treat and cure lung cancer. So just like breast cancer has like the BRCA gene, there is some genes, ALK, EGFR, and KRAS. Again, not something that you guys would be tested over, but this is like a protein or a gene that's on that cell that if they do have those markers, they can take an oral pill and it will basically block those markers that are feeding that cancer. So I would put money that your cousin probably has ALK positive lung cancer. You should ask her. It's pretty rare for somebody that young to have lung cancer, number one. It's very, very rare. And for them to live for 10 years. That's pretty impressive, really. So when these markers were first coming out, I was working in this field pretty heavily, and I went to a conference, and one of the lung cancer doctors there was presenting on these mutations, and they thought this was like the saving grace, and they were super excited, and his comment said, people are gonna start smoking because now they have a cure. Which that kind of stuck with me. This was years ago. They obviously still don't have a cure, but it's a very small percentage of people that have these mutations, unfortunately. So just a side note. So some risk factors. Incident increases with age. So usually it's diagnosed in people 60 or over. It says 50, but typically 50 or over. I'm glad somebody laughed at that. Maybe. Smoking, we know, ionizing radiation, inhaled irritants, radon is a huge one. And then if they have those oncogenes or those markers in their cells and in their DNA, then they know that those are things that will feed that cancer and make them much more prone to getting it. Okay, so how can we prevent it? Obviously, if somebody does smoke, educate on smoking cessation. I think it'll be really interesting to see if vaping, because the people inhaling all these things through vape, what that's gonna do in this area. They don't know because it hasn't been around long enough. People haven't been vaping long enough to really know the long-term effects of their lungs. But we know one of the risk factors is inhalants, right? So if people are vaping chemicals into their lungs, we know that can't be good on the cellular structure, right? Eventually that's gonna break down their DNA. These cells are gonna mutate. So I would, just from knowing that knowledge, if I had to guess, or if I was a gambler, I would bet we're gonna start seeing a lot more young people in 10, 15 years getting diagnosed with lung cancer. And I bet there will be a correlation with vaping. That is totally 100% my own speculation. Okay? So if somebody does smoke, if they quit before age 40, it does decrease their risk pretty significantly. They're still at a high risk, but if they quit before age 40, then it does decrease it. So try to prevent environmental and occupational exposure. Make people aware of exposure. I feel like a long time ago nobody knew what radon was, where now there's commercials about it. The real estate world has kind of latched onto this as an opportunity to make money, which I don't think is a terrible thing because it is truly a wellness prevention. Like if any of you, if you guys buy your first homes, make sure you check it for radon. Because there is very much a direct correlation.
There's no tornado in the forecast.
Good. We're all safe. Asbestos is another one. So really old buildings used to have a lot of asbestos in them. Also, there's some correlation with like Agent Orange that caused lung cancer. So any of you guys know what Agent Orange is? Like veterans. So in the wars, so people who are very old would have been potentially exposed to this. They used it as like gas in the war, like way back when. Most people who probably were exposed are probably nearing the end of their life due to old age. But there was a direct correlation with some veterans who were exposed to this chemical gas that they were being diagnosed with a lot of lung cancer later on in their life. Okay? So how does it present? Typically, they don't show any signs or symptoms until it's too late. So that's why causes a lot of mortality. A lot of times, the first place it's going to spread is the bones or the brain. The liver is also a place that lung cancer cells like to go to. But most often, especially small cell lung cancer, will spread to the brain. So much that anytime anyone is diagnosed with small cell, they sometimes will do prophylactic radiation to their brain. So even though they don't have any tumors there that they can see, they'll give them a very low dose of whole brain radiation because there's such a high risk that that will eventually spread to the brain at some point. And remember, chemo doesn't pass that blood-brain barrier. So very high risk to spread to the brain, both for small cell and non-small cell, but especially small cell cancer. The lymph nodes, so oftentimes it will surround the lymph nodes within the chest wall, and then bone mets, or I've seen a lot of cases where I told you guys about the guy that came with like a horn on his head, and it was lung cancer. That was his only symptom. He didn't have a cough, he wasn't short of breath. After he got diagnosed and started looking back, he said, oh, I have been really extra tired, but we're all tired, right? So they don't always recognize fatigue as a symptom until they've had treatment and they actually start feeling better. You need some energy back. So symptoms of brain mets. So if you have a tumor sitting in your brain, what kind of symptoms do you think someone would present with?
Headache.
Headache, potentially, depending on where it's at. What? Maybe. Usually doesn't start to affect like cognition or memory until it gets pretty large or there's a ton of swelling. What do you think the main one is? What? Vomiting and projectile typically. Okay, so vomiting, nausea, vomiting. There's another really big one. You have something sitting in your brain, it's going to affect the electrical activity in your brain. What's going to happen? You're going to have a seizure. So a lot of times people are diagnosed because they have a seizure and that's the first symptom they ever have. And they'll go in, they'll have an MRI and they have this huge tumor sitting in their brain. Then they'll start doing other scans and looking like, wait a minute, is there something else going on? Okay? A lot of times bone mets, so back pain, usually in the spinal area it'll go to. Sometimes it can affect their speech or their tone of their voice, depending if they have a tumor sitting up high, more in like the bronchial areas, or that affects the trachea. So sometimes they can like have a change in their voice, and that might be their only symptom that they have. Or maybe they're just hoarse. If somebody goes in and tells their doc, hey, like my voice just has been really hoarse, it's not like I've been screaming or there's no reason, they might do a chest X-ray just to make sure, hey, do you have something sitting here that's potentially causing inflammation that's affecting your vocal cords? Chronic cough, in more later stages, they can have hemoptysis or they're coughing up blood. That's pretty rare. You would think that'd be one of the early signs, but not always the case. Usually it's something else and it's already spread. I had another patient who had this very large tumor on his arm, and that was really his first sign. He was a big biker, and he kept noticing that his like leathers were tighter and tighter. Well, he had this huge tumor growing out his arm, and that was his first symptom that he ever had. and he was full of cancer, horrible lung cancer. So it has a mind of its own. It's an ugly, ugly beast. Sometimes it can have cardiac symptoms. I had a patient who had a massive heart attack, and they think he had a huge tumor sitting in his lungs. His bones were full of cancer. He never had pain, never short of breath. He had a massive heart attack. He says when they were coding him, that Jesus was standing at the edge of his bed, holding his toe, and said, "Do you want to live or die?" He said, "I want to live." He survived the code. He went through treatment for a little bit. He had some major anxiety. Didn't have insurance. He was self-employed, and his son was really his only support person. He was divorced and really didn't have any other family. And his son was in his 20s, so he didn't want to burden his son with this diagnosis. So he went on hospice, took him off all his meds. 2 years later, he walked into the cancer center, into my office, and said I was still alive. There's no rhyme or reason that man lived. And no textbook reason. He was literally full of cancer from head to toe. So there is miracles that happen every day that we cannot explain in nursing, and especially in this oncology world. It happens all the time. It's a crazy thing. It still kind of gives me chills like thinking about it. I can see his face. As far as I know, he's still living to this day. And that was probably 15 years ago. So what do we do for these patients? It's hard to take care of these patients because usually, like I said, they're diagnosed at a very late stage. They might be very sick when they're diagnosed. So we have to really find out what are their goals. What do they want for treatment? I've seen patients in their 40s who said, I'm gonna get my affairs in orders, I'm taking my family on a vacation, and when I come back, I'll die my own way. I'm not going through treatment, I'm not doing it. I've seen people in their 70s that fight nail and tooth every chemo to stay alive, to see a grandchild's wedding, or whatever major life event. So everybody is different how they handle it, but again, the prognosis is usually very, very poor. And so these can be really difficult patients to take care of. So treatment decision is based on the location and the type. So again, if it's squamous or adeno, depends on the chemo, because certain chemos work better on squam, certain chemos work better on adeno, not something you guys need to know, but that's how they determine what they're gonna get. Or if they do have one of those markers, then they can take oral medication, targeted therapy, which works way better, and they typically have a lot better prognosis. So if somebody does get diagnosed with lung cancer, they actually would want to have those markers on their cell because then you have something to use to fight it. They've also, probably within the last 2, maybe 3 years, have started to use immunotherapy. So remember, immunotherapy is tricking your body's immune system to fight it itself. So not chemotherapy. And they've had a lot of success with that. So there's patients out there who are living a lot longer with terrible lung cancer who probably should have died if they didn't have immunotherapy. So I drew lab on a patient 2 summers ago who she was one of the first ones who got a certain type of immunotherapy for lung cancer, and her oncologist told her, we really don't know what's going to happen because you're the first person who's gotten this outside of a clinical trial. So imagine if you were that person. Like, they didn't really know how long it's going to work because these therapies are so new, which I think is really cool in this world because they don't know. There's always something new coming out. So pretty cool, right? Okay, so how's it diagnosed? A lot of times incidentally. So there's been cases where people go in for surgery or going to have maybe they have to have some sort of cardiac procedure or knee surgery, hip surgery. Think of surgeries people might have to have when they're older. And they do a chest x-ray before they go to surgery just to make sure that they're healthy and their lungs are in good shape. And incidentally, they find a tumor. I've seen numerous cases where patients have been diagnosed that way. And usually in those cases, it's early stages. So lucky them that they were gonna have that hip surgery or knee surgery or cardiac ablation or whatever, and somebody recommended, hey, you probably need to have a chest x-ray done because it truly saved their life, that other procedure. where otherwise that would have continued to grow until they had symptoms. So chest x-ray, sometimes they'll do a bronchoscopy, so basically pulmonologists will go down their throat with a large scope and get a sampling of the tumor. So lung tumors are harder to biopsy because it's a very vascular area, and these cancers are very, very vascular. They suck a lot of blood supply from the patient to grow and mutate. So sometimes going in and biopsying with a needle can be very risky to the patient. Because if we're sticking a needle in someone's lung, what are we putting them at risk for? Pneumothorax, right? That lung could potentially collapse pretty easily, especially if it's already compromised and has a large tumor sitting in there. So sometimes they'll have to bronchum, go down their throat to get a sample of tissue. They use CAT scan to get a good picture, better than x-ray, and then a PET scan to see if it's spread anywhere. Sometimes when they're diagnosed, they might go in because they're really short of breath, and they have pleural effusion. So they have a lot of fluid surrounding that lung, so sometimes they'll sample that fluid. That's his cytology. If that has cancer cells in there, then they have a worse prognosis because it's already spread and is sloughing off cancer cells into the fluid surrounding their lung. Worse prognosis. Lab tests, so if they're severely anemic or if they have bone mets, then they might have really high calcium or low sodium, which I talked about in a little bit. There is some correlation. People with tuberculosis have a higher risk, so they can do a TB test and it will give them a false positive. I wouldn't put a lot of money on that as a diagnostic test for lung cancer, but your book says that. They'll do pulmonary function tests to see how strong their lungs are. So are they able to actually go through surgery? So I've seen some people in their elderly age, or maybe they had smoked their whole life and their lungs aren't very strong to make it through surgery, but they have a very early stage of lung cancer. So sometimes they can just go in and do radiation then instead to avoid putting them through surgery, because some people might not survive the surgery. They can do ABGs, again, to see, are they exchanging oxygen, carbon dioxide as they should, okay? So surgery really is the only chance to cure for both non-small and small cell lung cancer, but they'll only do it if it's caught early. If they already have disease that's spread somewhere else, so if it's in their bones, it's in their liver, they won't operate on these people because there'd be no reason. They already have cancer in other parts of their body. So most of the time they're inoperable, partially resectable. So sometimes if they have a very large tumor that maybe is sitting on their superior vena cava or is obstructing blood flow to somewhere else, maybe it's causing them heart problems, sometimes they can go in and debulk that tumor. But again, these tumors are very vascular, so they have an increased risk of bleeding. So a lot of times instead they'll use radiation to shrink it. But if they are lucky enough where their cancer is small enough or confined to one lung, and it's early stage, they don't have a lot of lymph nodes involved, it hasn't spread anywhere else, then they will try to do surgery to cure it, to get rid of it completely. So they can do what's called a wedge resection. So if you had a tumor sitting right here where this little triangle is, they'll go in and just basically take a wedge or a small piece of their lung out. Okay, it's called a wedge resection. They can do a lobectomy where they just take one lobe. So if it's confined to just one lobe in the lung and hasn't spread to any other lymph nodes around or outside of that lobe, they can do a lobectomy. So they take just the lobe out, leave them. You can survive with having one less lobe of your lung. Or they can do a pneumectomy where they take the whole entire lung out of one side of the body. And those people can survive with one remaining lung for curative intent. So what do you think if somebody had this procedure done, what would be some nursing interventions that would be priority? Both short-term and long-term. What do you guys think? If somebody's gonna have this surgery done, what would be some primary interventions you do right after surgery? What? What do you guys think? It's a beautiful next question right there.
Incentive spirometer.
Okay, incentive spirometer maybe. What would be most important? What are they gonna have after surgery?
Chest.
A chest tube, right? Because we just took a big chunk of tissue out of this person. Now we've left them with an empty cavity in their body. So until that heals, that's gonna fill with fluid, right? So they'll come out of surgery with a chest tube. With any type of lung surgery, they're gonna have a chest tube in place for a couple days. They're probably gonna be on a surgery floor, maybe in the ICU, depending on how big a surgery and how well they did. Okay? So, what are some considerations if somebody has a chest tube done? What are things you guys need to assess for? It's probably been a while since you talked about chest tubes, right? What are some major things we have to consider with somebody with a chest tube? What do we look for?
Bubbling.
Bubbling. Okay, and how should that bubbling be?
Mild.
Mild, okay. So as they breathe, there should be a little bit of titling, right? So as they're breathing, you should see a little bit of bubbling in there. You don't want continuous, right? If you walk in and you look in your canister or your chamber, thank you, and it's like, right? Like if some kid was blowing bubbles in water, then what does that indicate? What is that telling you? There's an air leak somewhere, right? Because you don't want all this air in your chamber. It should be a nice ebb and flow as they're breathing, right? Okay, what are some other considerations? They have a tube coming out of their chest. Infection, obviously, so you want to look at the wound, look around the site. Obviously, they're at a high risk of getting pneumonia, right? Because are they going to be taking a deep breath if their lung looks like this, their chest looks like this? It's very painful where they insert the chest tube. Patients that I know that have had this done say it's very, very painful at the insertion site. So pain. So is their pain under control? Because we want them to continue to take deep breaths, right? Because especially if they only have one lung left. If that lung gets pneumonia, yeek, right? They might be in bad shape. So we want to make sure that they're still breathing good. So incentive spirometry, get them up and moving, infection. What if you walk in and that chest tube is laying on the bed? It came out. What are you going to do? What are you going to cover it up with? What kind of dressing? But more importantly,
Silk.
occlusive, right? Or like a Vaseline gauze. Okay, because if they have a hole in their chest, you don't want to be putting air in here, right? Especially if it was this case where they had a lobe removed and the chest tube fell out, because potentially we could collapse this bottom lobe, right? Okay, so we're going to monitor for infection, bleeding. Look at the chest tube. Where should it be positioned? The canister. Down below the level you want it to drain, right? So common, you'll see they go down for radiation to have an x-ray, they come back, and the tech just leaves it laying on the bed. This happens all the time. Well, then is it doing its job? No. Or another common area you'll see is the tech will bring them back and put them in their room, but it's not hooked up to suction. Okay, so they have a lot of fluid sitting in that lung, and it's just a gravity. Is it going to drain that out? No, it needs to be hooked to your suction on the wall. What else should you be checking on your chest tube with your order? What? Output. So how much is coming out? Are they dumping mass volumes out? What does it look like? Is it bright red blood? Because it might be bright red initially, but then the more they get out from surgery, it should turn more sanguinous, serous, right? Also, is your suction going? So do you see that titling? Is it hooked up? And is it set to the right negativity that you want, that the physician wants it? So remember on the thing itself, it'll have like -20, -30, where you turn the little dial. The physician dictates where that's at. So you always wanna check your order and make sure that it matches, if you take care of somebody with a chest tube, that it matches where that little dial is set. You guys know what I'm talking about? Okay, so let's do a practice question. So who would you see first? What do you guys think?
See,
C, Adam's right. You don't want to see continuous bubbling. Why? We already talked about it. That tells you what's happening. There's an air leak somewhere. So if you see bubbling, what are you going to do? We have to figure out where the leak is coming from, right? Because is it coming from the chamber itself? As they took him down to radiation, did they bang the chamber against between the bed and the wall? This has happened. And they have a crack in the chamber. They have a defective chamber. Or is it somewhere in the tubing itself, coming out of the patient? Is it at the actual site of insertion? So we have to determine where is the leak coming from. So do you guys remember how you determine that? I'm gonna grab a chest tube. This might make it, this might make it a little easier. Can you see it?
If it, yeah, that's where you're checking.
Okay, so if we come in and we see a lot of bubbling down here, then we know there's a leak. And this is hooked up to our patient. Okay, or this is inside our patient. So where should we start looking for the leak first? Should we go from this way to the patient or start at the patient? What do you guys think?
Patient.
First, you'd want to assess your patient, right? Are they in bed gasping for air? That's a problem, right? If they're not short of breath, they're oxygenating good, then this leak isn't really doing enough to harm them yet, right? So what would we assess right at the site? How would we know if there's a leak right at the site? Remember what that's called when you feel around and you feel like Rice Krispies? Crepitus? Means there's a leak at the insertion site. So maybe the dressing has just been pulled off enough that a little bit is leaking out. So we might need to reapply an occlusive dressing. Sometimes surgeons will stitch these in. Typically they are stitched in. Maybe a stitch has been pulled enough or it's pulling that it's causing a little bit of air to leak. So we might have to reapply an occlusive dressing or consult the physician and say, hey, I think there's a leak at the site, right? So if we know it's not coming from here, we don't feel crepitus, our dressing is nice, tight, and secured, clean and dry, then we start looking at the tube, right? So on there you have this clamp, which is used why? For this reason, right? So if we go down the tube a little bit and then clamp off, and if we still see bubbling, then we know that maybe the leak is somewhere further down, right? So then you keep moving this down until your bubbling stops, and you might have to change out your part of your tube if it's coming from there, or they might have to call a surgeon, right?
Yeah.
Are you guys with me? All right, so we don't want bubbling. That's the key. There. I'm gonna breathe hot about chest tubes a little bit. All right, so what else do we do for these people? They're gonna get chemotherapy and usually a combination of chemo with radiation. Sometimes they do them together, depending on the size of their tumor and the type, and what stage it's at. If they typically have stage 4, which most do, they'll usually just get chemotherapy, unless they have a very large tumor that is causing them pain or disrupting their breathing. And sometimes they'll do radiation just to try to shrink it down. Obviously they're gonna get bronchodilators to help with their breathing, pain management, new targeted therapies I already talked about. They'll also get radiation. So what are some considerations if somebody's getting radiation to their chest wall? What do you think some nursing interventions would be? check their skin, right? They can have skin breakdown, breathing. When they get their lungs radiated, it can actually cause their lung tissue to become really hard and scarred, or pulmonary fibrosis. Now, it's not something you're gonna see right away, but it's something they'll be educated on early on. Now, a lot of patients think, well, I might not live long enough for that side effect to happen, so I'm gonna take my chances. Not everybody gets it, but it's something they should be educated on. So we have to constantly be monitoring, are they short of breath? Are they coughing up any blood? Remember I said these tumors are very vascular. If tumors are near a blood vessel, if in that blood vessel receives radiation, that vessel becomes very weak. A lot of patients with lung cancers can, if the tumor grows through a blood vessel or an artery, they can actually bleed out. I've seen this. It's horrible. It's horrible for the family to see, but it can be very common. They have these large tumors sitting in very vascular areas. They erode through a blood vessel. They will puke blood. They will have blood coming out of every orifice. It's very horrible. The patient doesn't know they die pretty quickly, but for the family, it's very horrible. So code status is a great thing to talk about with these patients, because do you want to code someone who is bleeding out? No. I told you guys about my first code. On the floor, the patient didn't have any legs. She started coughing and literally blood was splurting the walls. It looked like a murder scene in there. Because she was a full code, every time he did compressions, blood was coming out of her because her tumor literally burst or pushed through and busted one of her arteries inside. So, horrible. So, considerations for radiation. They can do external beam, which you guys kind of saw. We talked about beams coming from the outside, treating them. So they have to be really careful about not damaging any healthy heart tissue if it's near the heart. So they're really considerate about that. Again, sometimes what is more the risk or the benefit? I save their life and they might have some cardiac issues down the road, or we do nothing and they don't have a very good survival. And then they can do brachytherapy, so if they do have a really large tumor that is occluding their airway or their bronchioles, they can go down and give like a high dose, one-time treatment to try to shrink that right away. Very commonly done as well for people with large tumors where they can't breathe. Okay, so some just pictures of radiation. So this bottom one here would be brachytherapy. So they put the catheter actually down their nose and then hook it up, and the radiation machine gets a very high dose. Again, as they're blasting these tumors, there's a risk for bleeding, a very high risk for bleeding. So suction is very important to have ready. They've had patients that have had this done and have blood out during the procedure. They can get radiation burns. So again, skin, have to monitor their skin. Obviously, they wear a mask if they're getting like their brain radiated because it's spread. So staging is 1, 2, 3, and 4. It's based again, just like before, the tumor size, so how big it is. So if it's less than or equal to 3 centimeters, it's stage 1. Greater than 3 centimeters puts them into the stage 2 category. And then stage 3 has to do more with if it's larger than like a 4 or 5 centimeter, or if they have a lot of lymph node involvement, but confined to the lungs. And then stage 4, obviously it's spread outside of where it initially started. So even if it's started in one lung and it spread to the other lung, they'll consider it stage 4.
Are we gonna have to know the stages for each one?
No,
Like,
not specifically. Like, I'm not gonna say, oh, a patient has a 5 centimeter tumor, what's their TNM? No. I've never seen that on anything NCLEX related. It's more so if, to you guys, if somebody says I have stage 4 cancer, then you know that it's spread somewhere else in the body. Like, what does that really mean? Or stage 3, then it probably means they have a larger tumor with probably some lymph node involvement. If it's 1 or 2, means they have a smaller tumor, probably not lymph node involved. So it just helps you kind of better understand. I don't test you over the stages. I've never seen like specific NCLEX questions related to staging. Okay? So prognosis is very, very poor. The prognosis for anyone diagnosed with lung cancer is typically 18% chance of surviving 5 years or longer. 18%, pretty low, right? And that is because it's usually caught way later. Now, if it's stage 1, it's still 75% chance of survival. So when you guys ever see survival for any type of cancer, this is based on 5 years from when they were diagnosed. Because in the first 5 years is when, if it's going to spread or come back, the risk is the highest in the first 5 years. And that's really for any cancer, okay? So if you see like 95% survival, so that means from 5 years from diagnosis, they have 95% of survivors. So you can see for lung cancer, it's 75%. That still doesn't seem super high, right? When you guys hear 75%, you feel that's a good statistic? Not really, right? So 25% of those people probably are going to survive, even with stage 1 lung cancer, because it's aggressive, and often it develops in, or it comes back. You might treat it, have chemo, and then maybe 6 months, a year later, it's back with a vengeance. Because typically when lung cancer or any cancer comes back, it's going to mutate quicker and worse. So a lot of times, it'll come back and bear its ugly face, okay? So not great. Obviously you can see if they have later stages of stage 3 even, it's 5%, stage 4 less than 5% of living for 5 years or longer. It used to say when patients were diagnosed with an aggressive lung cancer without any sort of treatment, they had 4 to 6 months to live. 4 to 6 months. With treatment, sometimes they had 9 months to a year. With some of the new therapies, they've put that out to 18 months survival. Now with some immunotherapies, people are living 5 to 10 years, which is pretty significant, obviously. Okay, let's talk about some oncologic emergencies. So spirovenous cava syndrome. So this is usually seen in small cell because it does grow so rapidly in such a large tumor. So this literally is when you have a large tumor sitting on the spirovenous cava. Okay, so what does your spirovenous cava do? It's a very large blood vessel. Right, it brings your blood back, takes it to the heart, right? Or brings blood back in, right? Okay, so if you have a large tumor sitting on there, these people potentially could have a emergency life-threatening problem pretty rapidly. So some signs and symptoms, they might be short of breath. They're going to look like they have right-sided heart failure because everything's gonna back up. So they might have orbital edema, like edema around their eyes, puffy face. They might feel more short of breath in the morning. For females, it might feel like they have something sitting around their neck for whatever reason, or discomfort if they button their shirt, like their top button, they can't button. So pretty common. So what do you think they would do for somebody who has spirovenous cava syndrome? What are they gonna do? You have this large tumor sitting on a huge blood vessel. What? They won't redirect their vessel, it's way too risky. They would bleed out and die. Sometimes surgery remove it, usually they'll do radiation and steroids. So put them on very high doses of steroids and then they will radiate that area right away and try to shrink that and pull it off the spirovenous cava. Okay, pleural effusion is obviously when they just get that extra fluid in their lung. Typically if they test the fluid in there, those cells will have cancer in there. Obviously if there's way too much, it could potentially collapse their lung, right? Sometimes people for palliative care, they will actually have to get a drain placed to where they can basically do their own like thoracentesis if they need to, right? So they might have like a little catheter that sits in the lining or near the lining of their lung. They start to feel short of breath because they might, in end-stage lung cancer, maybe they might drain anywhere from 500 to a liter off their lung every couple of days. It can be very common because this cancer is so aggressive and it's basically damaging their lung, and so it's trying to, as their body tries to get rid of it, it pushes this fluid around that lining of their lung, And so they can drain it off themselves, and they can drain lots of fluid off. So obviously they're very end stage at that point. SAIDH, so anyone know what that stands for? I think you guys have learned about this at some point.
Something diuretic hormone.
Syndrome of inappropriate antidiuretic hormone. Okay, so what does that mean? You guys learned about this, right? It's deep in your brain somewhere. What is SAIDH? So basically, the body starts to produce more of this antidiuretic hormone because the kidneys are hanging on to extra fluid. So the body thinks that it's dehydrated when really it's not, in a sense. They're not really sure the correlation of why this happens with people with huge tumors sitting in their lungs, but it can sometimes be how people are diagnosed. So they'll come in to maybe the ED, and somebody will be extremely confused, and they'll draw a set of labs, and their sodium will be really low, below 120. And so they'll replace the sodium, the confusion goes away. But if they scan this person's chest, they might find a huge tumor sitting there, and it's causing them to get SAIDH. So basically, the kidneys aren't excreting extra fluid, but yet they're pulling sodium out of the cells to try to make more fluid. So low sodium below 120, SAIDH, can become a medical emergency. They can get confusion. In severe cases, they can actually start to have seizures, can go into a coma, and it can kill them if they don't replace their sodium. Very common, can happen with either type of lung cancer. And then spinal cord compression. So this is where you have a large tumor that has metastasized somewhere in the spine, and basically it's shutting off the nerve supply or putting enough compression on the spine where if that pressure is not relieved right away, it can cause permanent damage. So these people can lose bowel and bladder control. So if they have a sudden onset of pain or a sudden onset of numbness and tingling below, like usually in their legs, because it often happens kind of in the lower spine or kind of sacral area. This can also happen with like prostate cancer, rectal cancer, any cancer really that spreads to the spine, and you have a large tumor sitting there that potentially starts to destroy those nerves. And if you don't get that tumor away from those nerves, you will damage them permanently, and they'll have permanent paralysis. So this isn't something that's going to kill them, but potentially you could cause them long-term nerve damage or paralysis. So again, they would put them on high doses of steroids, try to shrink the inflammation, and do radiation right away, high doses to the spine to try to pull that tumor away from it. They usually rarely will go in and do like a debulking surgery, just because now you have a person with horrible cancer, and now they need 4 weeks to recover from surgery before we can do anything else. Well, guess what? That's probably going to grow back and kill them within that 4-week window. They don't have time to wait 4 weeks for to start treatment. So that's why they tend not to go towards surgery. Or like superior vena cava. If you have a large tumor sitting there, they don't want to have this big cardiac surgery. Now your person's in the ICU for a couple weeks. They have to go to rehab. They're going to die before they ever get treatment. So a lot of times that's why they'll use radiation first. More external, less invasive. Okay? So if somebody presents with superior vena cava syndrome, they might be short of breath, congestion, have severe facial swelling. Their face might look really red in the mornings when they wake up, because why? They have this huge tumor sitting on their superior vena cava, so everything is backing up into their upper body, right? So they have extra blood flow. They might have high blood pressure. You should see jugular vein distension. They might be cyanotic in other places, have some peripheral edema, eye swelling or orbital edema. They could potentially have altered consciousness in severe cases. I really haven't seen that. They could be hoarse. I had a 46-year-old patient once who came in, kept going to his primary care because he had all these symptoms basically. He'd wake up in the morning really congested. They were remodeling their house at the time, so he just thought, oh, we have a lot of dust, sawdust from this huge remodel. But by the end of the day, the swelling would kind of go down because he was up, moving around, right? The body compensated. Well, it started to get worse and worse where he felt like there was something sitting on his chest, so he actually went in because he thought maybe he was having a heart attack. Well, they finally scanned him and they found this huge tumor sitting right on his spira vena cava. So he had major spira vena cava syndrome. So he came in for aggressive radiation, steroids, and was diagnosed with small cell. So more common in small cell lung cancer. So things you need to know taking care of these patients, usually a very poor prognosis. Like I said, without treatment, they will die pretty rapidly. I've seen patients who started treatment and have died the next week, died a couple days later just because they had so much cancer in their body. It's a very poor prognosis most of the time. Treatments are getting better and better, people are living longer, so there is some promising stuff out there. So obviously as nurses we have to monitor respiratory status, the cancer itself, how are they feeling about it, what is their overall goals? Do they have spread somewhere? If somebody has bone mets, it's very, very painful. If you have a tumor that's eroding away your bone, most opioids are not going to touch that, especially if it's sitting on a nerve. So there's people that get intrathecal pain pumps where they have constant pain meds running into their system. They can try to do nerve blocks sometimes. They'll try alternative pain things. Sometimes they're on like antidepressant meds, or they'll use antipsychotics. Some of those in really small doses will actually help pain. So try lots and lots of different things. Palliative care has been huge for people now because sometimes they can try other things, massage, acupuncture, lots of different things to relieve that severe pain. So obviously impaired gas exchange, surprisingly enough, they don't always have a lot of breathing issues until really end of their life. You'd think if they have really large tumors that they'd be really short of breath. That's not always the case because the body tends to compensate. Cardiac problems, if it is like spira vena cava or it's affecting their cardiac output, obviously, activity intolerance, pain, breathing is probably a huge one. And I feel like people diagnosed with lung cancer, if they were smokers, they have a tremendous amount of guilt, right? And so a lot of compassion from a nursing standpoint of, you know, yes, you smoked, should you have smoked? No, but for a lot of people who were diagnosed at an older age, remember smoking was cool, right? It was really, if you didn't smoke, you weren't cool. We didn't know it caused all these horrible things to happen. Like our generation, a little bit of my generation, definitely your guys's, grew up that smoking was bad, right? So if anyone in your generation smokes and gets lung cancer, they might have a reason to be guilty. But really, older generations, they were really told you should smoke, right? It was the cool thing. It was on the commercials, like everyone should do it, right? The Marlboro Man and all these things. So the guilt sometimes is harder for them to handle than the actual diagnosis itself. So sometimes helping them get through that guilt can be a big intervention that you have to do as nurses. And a lot of that is through like therapeutic communication. So like what would you say to them? Right? So promote healthy grieving, spend time with the client and the family, answer their questions honestly, talk to them about what are their end of life wishes. Do they have a DNR? The worst thing you want to see is somebody with this huge lung cancer coded and they survived the code, but guess what? We didn't cure their cancer just because they survived a code. And now we've just delayed their treatment. So to really have those hard conversations of even if you stop breathing, yes, you want to live, yes, you want to have a chance of trying to cure this, but if we have to put a tube down, you may never get off that ventilator, right? You're still going to have your cancer even if you cope. So have those hard conversations. Do they have a living will? Do they have a power of attorney? Set realistic goals with them. Patients will always want to know the prognosis, and sometimes oncologists are not the greatest about giving it because sometimes it's hard for them, I think, or they don't want to say, we have 4 months to live, and then the patient just gives up. Because we don't know, right? Some people outlive their diagnosis. Like the Miracle Man is probably still living. Okay, so be realistic with them, but help them set realistic goals. Have those hard conversations. Okay. You guys need a break? Get up, move around, get some water.
Hmm?
I thought we were gonna go till 11.